Hello, and welcome to Riverside Reflections. I'm your host, Denise Mananis, Associate Vice President of External Affairs at St. John's Riverside Hospital, and today's guest is Dr. Stephen Erosa, Interventional Pain Management Specialist with St. John's Medical Group. And by the way, you are also the Assistant Medical Director of the medical group?
Yes, this year.
This year?
Yeah.
That's what I thought. That's really great. We're so thrilled.
Thank you.
So, Doctor, welcome.
Thank you so much for having me. I appreciate it.
Yeah, we're thrilled to talk to you. I would like to start with just educating our community and our audience on what is interventional pain medicine.
Interventional pain medicine is a specialty of medicine where we're focusing on diagnosing and treating complex pain problems from head to toe all throughout the body. We utilize diagnostic testing and imaging to identify the actual source of the pain, whatever that pain, what we call pain generator might be, and then apply an intervention, a procedure, a nerve block, maybe an ablation or some other minimally invasive treatment for that problem.
So that pain generator, can you go into pain? Most people think of pain, they think, oh, my foot hurts, my knee hurts. You know, they think arthritis in general causes most of their pain. Mm-hmm. Well, give me some idea of what pain is, where it's coming from.
So everything you just said, right? So patients that have arthritic joints, that is a pain generator. Patients that may have had a trauma and they have what we call nerve pain or neuropathic pain is a fancy term for this. But it's that sensation of like tingling or burning or a numbness that's nagging or like diabetic neuropathy. My feet always feel like sandpaper. They feel like they're on fire all the time. Those are the different types of pain that exist. And sometimes they're mixed. Sometimes they're an arthritic component and a nerve component for whatever reason. And we have very specific treatments for that. So when it comes to types of pain generators, it also comes to location. Well, is it my neck? Is it my foot? My foot hurts. Is it actually a foot-related problem or is it a spine-related problem?
Oh.
So a lot of these things are connected, and that's where the diagnostic part of the interventional pain practice comes in to identify why does my, for instance, leg and foot hurt? Is it a problem there or is it a problem somewhere else?
That's interesting. So this is kind of a new field, pain medicine, as a separate field, yes?
Yeah, so pain medicine as an accredited specialty was accredited in 2004, 2005.
Wow.
Which means that in the last 20 years, we've had trained doctors specifically fellowship trained and boarded in this discipline.
Which I'm assuming you're fellowship trained and
yes.
boarded. Yes.
I'm both boarded in physical medicine and rehabilitation and interventional and pain medicine.
Okay.
So a lot of the newer technologies and procedures are being rapidly developed. It's a evolving field.
So what interested you in this particular field?
I'll make it brief.
Okay.
I went to osteopathic medical school. Mm-hmm. And as a DO, I was trained in using my hands to treat conditions of the spine, joints, nerves, and bones. I'm actually pretty good at it. I do utilize it in my practice when appropriate for patients. And that led me down the path of I want to do something in the musculoskeletal medicine, orthopedic realm.
Interesting.
And as I went through that process of rotating through the fields of sports medicine, orthopedic surgery, and all these things, I found myself at physical medicine and rehabilitation. And it gave me everything that I wanted out of medicine. I wanted continuity of care with my patients. I wanted to see them through these long-term problems that they were having and help find solutions to very complicated conditions. That led me to the pain practice because I like doing procedures. I like hands-on work, and I like seeing patients get better from something that I've done with them. So from being an osteopathic physician and being interested in musculoskeletal medicine, that led me to the rehab aspect and then the interventional pain practice. I did a rotation when I was a medical student in 4th year of medical school.
Wow.
And I sat there, was applied to all types of general surgery, multiple other surgical specialties. I did that 1 month. It changed my whole perspective. I went back, I applied, and I've never looked back, and I'm doing everything I want to do.
That's really actually inspiring. I don't hear very many people who express that level of satisfaction. So there is an interesting component of this that I wanted to touch on, having given me all of that. The philosophy of care that you have in your practice. Can you speak to that a little bit?
So the idea, and I guess the message of what we're trying to do at St. John's and in the medical group is to provide advanced interventional pain care and rehabilitation without the need for prolonged or long-term opioid medications. Yeah. So pain management has a reputation or a history. It's all over the news. It's all over Netflix and Hulu and all these specials and TV shows, which are great, by the way. But they talk about a time when pain management was just oxycodone and OxyContin. Now, there is a place for these medications. There are patients that need these medications. But the overutilization of it and the over-reliance on it
led to a national crisis.
Yes. And now what we're seeing is an evolution of the practice into the interventional space where we can actually do things for these chronic pain patients to alleviate the pain and let them live their lives in a more functional manner. We at St. John's here perform all the regular traditional interventional treatments, from epidurals to nerve blocks and ablations and joint injections, both ultrasound guided in the office setting and in the hospital, and x-ray guided in the hospital proper, because we do procedures in both locations. But some of the new or novel procedures that I'm very proud of are neuromodulation, which is a fancy term for nerve stimulators. We are changing the way the nerves are processing pain and stimulating these nerves in a way to calm down focal pain, both in the joints, in the back, in upper extremities and lower extremities. We have treatments that are temporary, that you use for a short period of time, but could give you up to a year or longer of relief. We have treatments
That's amazing.
It really is, because up until I guess maybe 15 years ago when it was studied, but probably 6 to 7 years ago when it actually came out, there was no temporary implant that provided durable relief.
So you have that one that goes up to a year, and then there's one that lasts long that's more permanent?
We do have permanent solutions, and we offer all of the different permanent solutions that exist nowadays for stimulating nerves in the periphery or the limbs, and ones that we stimulate from the back diffusely throughout the body. And so some of those are permanent implants, but our philosophy is we're going to go from least invasive to quote unquote most invasive.
Right.
And of the most invasive that I do, it's way less invasive than many other potential options for managing these types of conditions.
Okay. So the conditions that you're talking about that would progressively would be more surgical, fixing of certain aspects of the spine or other things like that. So these are minimally invasive.
Yes.
And when you say implantables, what exactly do you mean? Like, where does it go? What is it? Is it a thing? What is it?
So it is a thing. We have one category with the stimulators are little wires. So some of them range from the size of a hair to an angel hair pasta to a spaghetti. Those are the different gauges of wire. Okay. And then there's a little implantable, which can be like a dime to like a size of a pacemaker device.
Okay.
And those things we get placed under the skin after a trial period. You try before you buy. We don't just put things in and see if, hey, does it work now? We'll know that it's going to help you before we decide to do something a little bit more permanent. And so those are those implantables. And now on the cutting edge of interventional spine are things where we are, from an implantable perspective, putting very small devices, whether it's a tiny screw or a tiny spacer, right next to areas of the back or spine, all through a small incision and done under local and twilight sedation, so that you are able to get up and leave the hospital and go back to your normal activities the following day.
And no pain.
Less pain. Shortened recovery.
Okay.
And the goal is that these treatments are for patients that either don't want to undergo a larger surgery, invasive surgery
Yeah.
with long-term recovery, or better yet, patients that are not able to. What do these people
that's
do when they
interesting.
can't have that procedure? This is where we come in as interventionists to help, because it's a multidisciplinary approach.
So, doctor, I want to sort of turn our attention a little bit to talking about some of the patient stories that I know, because so many of our employees and their family members have come to you because they've heard wonderful things. So, can you share some stories with us just to illustrate what you do?
Sure. One particular patient comes to mind. She was a patient that had chronic foot pain and underwent a surgery to help correct that foot pain. And unfortunately, a very rare complication that can occur with any type of surgical procedure or ankle fracture this can happen with, she ended up having. And that's something called CRPS, or something called complex regional pain syndrome.
Okay.
And that's one of those nerve pain syndromes. I'll describe it for you. It's chronic pain that feels like your skin is either tingling or electric shocks or severe pain to things that should not be painful. Putting on a sock hurts. Having your sheet on your foot at night while you're in bed causes pain.
Wow.
That is how sensitive the affected limb can be. And she had all of these symptoms.
Is
which
this like a
was pain.
fibromyalgia type of pain, or is it different?
It's a
from that?
little different. So
Okay.
fibromyalgia, in the sense that yes, it's a nerve ending type of pain problem, but let's consider fibromyalgia to be like something that's easy to deal with.
Right.
CRPS is one of the highest levels of pain somebody can have.
Wow.
And it's very debilitating. The typical treatment is medications, physical therapy, and that's standard. She saw me maybe 8 months into her treatment course and was not seeing any improvement. We talked a lot about different treatment options. We actually, as a team together, decided on doing some shots first, and we did some blocks, and they provided minimal relief. But then we discussed a type of stimulator option that is temporary, that does not get permanently implanted, doesn't require any cutting. It's all done through the skin, through a needle. So it was very minimally invasive. And she wanted this option because of her history and what had happened prior. So we did it. After 60 days, we removed that wire. She was 90% pain relieved. And the best part about this is, to this day, she's 90% pain relieved.
So even though it was a temporary procedure, it's had long-lasting effect.
Absolutely. It's the only treatment of its kind that has durable, lasting relief without a permanent implant. And so now she can wear her shoes, she can walk on the beach on sand, she can lay in a bed with a sheet on her foot, which we all take for granted, and not be awoken from sleep. So it's
amazing.
It's one of my best outcomes and my favorite patients, and I'm just very happy that she got that relief. 5 years ago, I would have said she has to absolutely have a permanent implant. There's no way that we're going to manage this pain.
So this was a temporary implant, and it had lasting effects?
It's the only system in the world that has data and a design to support long-term durable relief after just a short-term implant.
That's really interesting. When you have a patient, I don't know if you have any, I'm thinking of someone that I'm related to who is older, who has considerable arthritis of the spine, as well as other couple of joint replacements. And the presentation of pain is elsewhere than where it's coming from. It's coming from the spine. So what kinds of things can you do for someone like that? Because I think there's an awful lot of people who are aging, me too, and beginning to say, why does that hurt? What are those things that most people sort of just resign themselves to an Advil and I'll get through the day, and it just becomes progressively more and more problematic.
So, and especially in the older population, lumbar spinal stenosis, which is basically arthritis of the spine, and that arthritis starts to encroach upon the nerves within the spine.
Okay.
Patients will say, oh, when I get up and I walk around, I start to feel this achiness in my thighs, and I can't go as far as I used to, and then I have to sit down, and then I have to wait a few minutes, and then it comes back. But then some days I'm okay if I stretch, but it's always nagging them. That they may find that the symptoms are mostly in their legs and not necessarily just in their back. But when we assess this further, we find out that that's what actually is occurring.
Okay.
And then we can do things like epidural steroid injections to help calm down some of those symptoms, as we put some medicine inside of the spine.
Right.
And then along those minimally invasive lines, there are procedures where we can actually do a small shaving of an area. Same thing under local, I've done these. Same day procedure, the patients go home, that space opens up a little bit, and they can walk farther, they can walk longer, they can stand longer with less pain or no pain. And it actually helps them be more functional without undergoing bigger procedures. So those are one of the aspects of that type of that pain, where it's coming from the back.
It's incredible. I mean, the job satisfaction that you must have from the way you spoke earlier, when you see people do well. You have another story that you can share with us?
Sure. We talk about patients that have been in pain for decades. I deal with chronic pain. So most of the procedures are geared towards that. We do help people with acute pain, and that definition is less than 3 months of pain. We call that more acute pain, because by then you should get better. After 3 months, if you're not better, we call that kind of chronic pain, and we try to work with that. Some people are in pain for decades. We had a patient that was in pain for 20 years, had undergone all the procedures that I had mentioned,
right,
the blocks and the epidurals and ablations where they shut off nerves, lots of physical therapy, lots of medications, and was kind of resigned to, I'm just going to have back pain. But when we get back to the diagnostic aspect of what I do, there are changes in the spine where there's arthritis in areas that we were unable to treat before. Now we have a treatment where we can address that very specifically. We did this procedure for this patient, and after 20 years of being in chronic back pain, he reported 80% improvement in his pain 3 days after we did this procedure. That is phenomenal.
That is phenomenal.
And it's because, not that we made something up or something new or some magic occurred. He had a condition that we just did not know how to treat. And now in 2025, we have these treatments, and we have them here at St. John's. So there are thousands of people walking around that have had chronic achy back pain, but the tools weren't available. Now they're available to us. They don't need medications. They don't need to be on long-term drugs.
Right.
We have an option.
That's very interesting. Can you just talk a little bit about the partners in what you do? You've talked about physical therapy.
Mm-hmm.
So what's the role of physical therapy really for someone with arthritis? Does it help? Does it make it better? Because a lot of people are like, oh my God, I'm tired. It hurts. I don't want to do it. What's the story with physical therapy and exercise?
And exercise.
Yeah.
So the physiatrist in me, the physical medicine rehabilitation doctor, just did this for 3 years. We prescribed physical therapy for all these conditions. And there is a wealth of data to show that for everything that I have a treatment for with a device or a procedure, that physical therapy can help. And the reason is arthritis likes movement. A stiff, achy knee hurts when it's stiff and achy, but when it gets up and it walks around and it
stops being as achy.
It stops being as achy. The problem is getting that motivation to go and do that.
Yeah.
And so I encourage all of my patients in our treatment plan is that physical therapy is extremely important. We can do a shot. We can do medicine. When I say shot, let's call that a procedure. We can do a medication, and we can do physical therapy. We could do them at the same time. We could do them separate. But at the end of the day, the one thing you're always is going to do is physical therapy, regardless of what you try. If you need the shot first to get your pain down, great, your pain is better. Now we need to start moving. Because sometimes part of the reason why you got into pain is because you weren't moving enough. So I'll kind of summarize with this. There are diseases of activity and diseases of inactivity. And whether you're pitching a baseball at 90 miles an hour and have shoulder pain, or you just don't move your arm all day and have shoulder pain, you can both have rotator cuff disease. It's that Goldilocks zone.
Yeah.
Not too hot, not too cold, just right, that's going to keep your body maintained.
Wow. Well, that's quite fascinating. Thank you for being with us. You've been wonderful. So I'd like to invite our audience to watch our Riverside Talk live interview with Dr. Erosa. That's also on our YouTube channel. And thank you for joining us today. Have a great day.